Bismillahirrahmanirrahim. The next topic of our discussion is colorectal adenocarcinoma. So, colorectal adenocarcinoma is the malignant neoplastic proliferation of the epithelial lining of colon and rectum. The normal epithelium that lines the colon and rectum is columnar epithelium, and the malignant cancer of this columnar epithelium of the colon is known as adenocarcinoma of colon. The colorectal adenocarcinoma is the most common GIT tumor, whereas it is the third most common tumor worldwide. The risk factors for colorectal adenocarcinoma include decreased dietary fibers. The dietary fibers actually result in fecal bulking and removal of the accumulated toxins in the gut wall. So the deficiency in the dietary fibers result in decreased fecal bulking and accumulation of toxins, which are actually carcinogenic and can result in formation of adenocarcinoma. Excessive use of refined carbohydrates and fatty foods also predispose to adenocarcinoma, and it also includes lack of physical activity. Hereditary polyposis syndrome is an intestinal disease which is characterized by the formation of polyps inside the gut wall, which can also transform into carcinoma. Ulcerative colitis has a greater risk of forming the cancer rather than the Crohn's disease, and smoking and excessive use of alcohol also predispose to formation of adenocarcinoma. NSAIDs, on the other hand, appear to have a protective function against the formation of the tumor. The NSAIDs actually inhibit COX-2 enzymes, which results in decreased production of the prostaglandins necessary for epithelial regeneration and growth. So decreased production of the prostaglandins result in decreased proliferation of intestinal epithelium. The pathogenesis of adenocarcinoma of colon is rather complex, but it is fully understood. The tumor involves the mutations of both tumor suppressor as well as proto-oncogenes, which accumulate over a certain period of time. The tumor develops in two ways. The first pathway is the APC beta-catenin pathway, which is also known as adenoma-carcinoma sequence, and the other is microsatellite instability pathway. So coming on towards APC beta-catenin pathway, so in this case, the mutations accumulate over the time in tumor suppressor genes as well as in the proto-oncogenes. The tumor suppressor genes include P53 and APC genes. APC gene is of typical importance in the APC beta-catenin pathway. Under normal situations, APC is an inhibitor of beta-catenin. Beta-catenin is a component of WNT pathway, and WNT pathway actually controls the cell migration, cell polarity, and organogenesis. So once the APC gene is mutated, there is increased accumulation of beta-catenin. So this beta-catenin upregulates the functions of MYC and cyclin D genes. One thing to remember in this case is the mutation in APC should be in the both copies. The mutation in the first copy makes the cells prone to developing a tumor, and the mutation in the both copies of the APC genes results in the formation of the tumor. So the mutation in APC gene results in an increased accumulation of beta-catenin. Since it is not degraded by the APC protein, there is upregulation of MYC and cyclin D genes. These genes result in increased proliferation and cell growth. In the late stage of the tumor, P53 gene also gets mutated. So the mutations in the tumor suppressor genes that include P53 and APC are actually the loss of function mutations, which means they stop performing their actual functions, hence resulting in the increased and excessive cell growth. The proto-oncogenes include KRAS and SMAD4 and SMAD2 mutations. KRAS gene, just like P53 gene, it is mutated late in the disease. SMAD2 and SMAD4 genes, under normal situations, are regulated by transforming growth factor beta pathway, and they inhibit the cell growth. So the mutations in these genes lead to increased and excessive cell growth, which results in the adenocarcinoma of the colon. Moreover, certain telomerase genes also get mutated in the late stage of the disease, resulting in the formation of an infiltrative tumor. So this here is a normal colon which does not carry any mutations. At first, there is the inactivation of the first copy of APC gene, putting the mucosa at the risk to develop tumor. In the next phase, there is the mutation of both the copies of APC genes, and there is mutation of KRAS genes, which result in the formation of the adenoma. Mutations in SMAD2 and SMAD4 genes, which leads to the formation of a carcinoma. The second pathway in the pathogenesis of adenocarcinoma of the colon is the microsatellite instability pathway. So what happens in this case, that the DNA mismatch repair genes are actually mutated. These mutations could be either inherited or they could be acquired during the lifetime. So the mutations in the DNA mismatch repair genes result in the inability of the cell to repair the DNA, which results in the accumulation of mutations in the microsatellites. So microsatellites are actually the repeated DNA sequences on the chromosomes. These mutations usually accumulate in the microsatellites present in the non-coding region. But in certain cases, the mutations are also present in the coding regions of the microsatellites. The genes mutated in such cases include transforming growth factor beta gene, PAX gene, which is a pro-apoptotic gene, and BRAF gene. The transforming growth factor beta gene is actually an inhibitor of cell growth, but the mutation actually results in the increased cell growth, resulting in the formation of tumor. PAX gene is a pro-apoptotic gene, and again the mutation in PAX gene result in inhibition of the apoptosis and proliferation of the cell. BRAF gene is a proto-oncogene, and the gain of function mutation in the BRAF gene results in increased and excessive cell replication and growth, leading to formation of adenocarcinoma of colon. So this here is a normal colon with the epithelial cells carrying mutations in the DNA mismatch repair genes. These genes are usually located in the non-coding regions of microsatellites, but in certain cases, there could be mutations in the coding regions of the microsatellites. The typical feature of the microsatellite instability pathway is the formation of sessile serrated adenoma. As you can see, this is a sessile and it appears to be serrated like a saw, hence known as sessile serrated adenoma. The mutations in the transforming growth factor, PAX gene and BRAF genes results in the formation of adenocarcinoma of the colon. The adenocarcinoma of the colon reveals a polypoid or exophytic growth in the ascending colon. Polypoid means forming a polyp, and exophytic means protruding outside the wall into the lumen. The tumors in the ascending colon usually grow along the wall of the intestine and usually do not cause the obstruction. Whereas in the descending colon, the tumor forms an annular lesion. The annular lesions grow in size, resulting in the obstruction of the colon. The first point to remember on the histology is the pattern recognition of the tumor. Since this is an adenocarcinoma, adeno means glands and carcinoma means neoplastic proliferation of epithelial cells. So adenocarcinoma of the colon forms the mucinous glands. As you can see here, these are the glands present in a tumor. The next point on the histology is the cell characters. The tumor cells could be well differentiated or they could be poorly differentiated. Well differentiated cells resemble the columnar cells in size and shape, whereas the poorly differentiated cells are atypical cells, which are round, have central nuclei, and they have abundant cytoplasm. As you can see here, this is a tumor which is portraying small round cells which have lost the polarity. Hence, these cells are poorly differentiated. Often signet ring cells are also present in adenocarcinoma of the colon, just like in the gastric adenocarcinoma. The signet ring cells are round. They have large vacuoles which push the nucleus towards the periphery, hence giving a signet ring appearance. The third point is specific feature of the tumor. The colorectal adenocarcinomas initiate a desmoplastic reaction which causes the deposition of excessive collagen, which is the cause behind firm consistency of the tumor. The fourth point is about the mitotic bodies, which are abundant in the malignant tumor. And the fifth point is focal necrosis, which is a hallmark of malignancy. Like all the malignant cancers, colorectal adenocarcinoma also has an insidious onset, and it usually presents in the age more than 70 years. The disease most commonly presents with the fatigue and iron deficiency anemia, which is either due to occult bleeding in the stool or due to lack of iron absorption. The patient also complains of abdominal cramps present over a long period of time, and there is a chronic history of altered bowel habits, which is more common in the left-sided tumor. There is also a history of excessive weight loss, and the tumor most commonly metastasizes to liver. The other sites of metastasis include lungs, lymph nodes, and bones. The diagnosis of adenocarcinoma is established on endoscopy and histological study of the biopsy. The prognosis is usually good in case of non-metastatic superficial tumors. Superficial means restricted to mucosa and submucosa. The invasion of tumor into the muscularis propria and metastasis are associated with the bad prognosis. The screening tests for adenocarcinoma of the colon include fecal occult blood test, which is the detection of red blood cells in the feces. Sigmoidoscopy and colonoscopy are also often performed. And the third screening test is DNA stool test, which is based on the detection of mutated genes in the cells, which are shed in the stool. So this brings us to the end of discussion about colorectal carcinoma. If you have any questions, do let us know in the comment section. Thank you.